Hello, my name is Ashwin Matani. I am one of the pediatric endocrine registrars working at King's College Hospital. And today I'm going to be talking about DKA using a case-based example. So our case today involves a 3-year-old girl who weighs 20 kilos and is obese greater than the 99.6 centile. She presents to A&E with a 2-day history of polyuria, polydipsia, and vomiting. She has a known background of type 1 diabetes with an insulin pump. The parents tell you they haven't been able to get hold of another cartridge for her pump, but found Lantus and was able to give that to her last night. What do you want to do? So hopefully you wanted to do an ABCDE assessment. So clinically, her airway is patent. She's groaning and she has a acetone hair drop-like smell to her breath. She has deep and labored breathing, but is saturating in air with good air entry. Cardiovascularly, she has dry mucous membranes, sunken eyes. Her cap refill is 4 seconds. She's mildly tachycardic with a heart rate of 140, but otherwise good pulse. And BP is 102 over 52. The nurses have done a blood gas for you. The pH is 6.97, bicarb is 4, potassium is 5.6, lactate is 4.0. The blood glucose on the gas is 33, and ketones, which was done separately, is 6.1. Otherwise, she's afebrile. Her ECG shows a sinus rhythm, and she is passing urine. Her GCS is 14 over 15. She's mildly drowsy, but rousable, and her pupils are equal and reactive. Her abdomen is soft. She has no rashes. She's not vomiting anymore, and you notice her pump tubing is kinked. What would you like to do next? Or, oh, sorry, what is your diagnosis? So you've probably guessed the diagnosis is DKA, probably based on the talk. But to talk about DKA, DKA is a life-threatening complication of diabetes. And the reason it happens is because if we want to refresh our pathophysiology, in type 1 diabetes, there's often little or no insulin. Insulin normally inhibits the breakdown of fat, lipolysis, production of glucose from gluconeogenesis, and production of ketones or ketogenesis. So without insulin, these processes go unchecked, and what the result is a hyperglycemia defined as greater than 11 millimoles per liter, and a ketonemia or severe ketonemia, which is defined as a blood ketone greater than 3. The high ketones result in a significant acidosis, which is defined as a pH less than 7.3 with a bicarb of less than 10. The relevance of this is that the BSPED have used the pH as a guide for fluid management in patients with DKA. So if you have a mild or moderate DKA, they would assume a 5% dehydration. If you were severe, you would assume a 10%. For patients that are in between, so some patients will have a pH of 7.11 but a bicarb of 4, it would be advisable to go with other clinical parameters or assume a 5% and reassess. So what would your management plan be? So in our 3-year-old girl, it is advisable to give 100% oxygen via face mask, even if she is saturating in air. She would need IV access with collection of bloods, and this is often a good opportunity to do her annual review bloods. Now, for her, because she has a known diagnosis of type 1 diabetes, the antibodies would not necessarily be required, but it is required for those children with a new diagnosis as it guides management later on. Another thing to consider is she was afebrile, but if she had any clinical signs of being unwell or history of fever, it would be worth doing a blood culture as this may be contributing to her acidosis, if not worsening it. as she may be septic. But the mainstay of management for her would be fluids. So you would make her nil by mouth. All children who are diagnosed with DKA, whether mild, moderate, or severe, should receive a bolus. The main question should be whether they are shocked or not shocked. So if they are shocked, and that is defined by, for example, a thready pulse, tachycardia, prolonged cat refill, which is often the case in most of these children with DKA. So utilizing signs more like the thready pulse or hypotension are more useful. Then you would administer the fluid bolus within 15 minutes and not include it in the total. Um, so I'll come to that in a bit. If they are not shocked, you would still give them a 10 ml per kilo bolus, but over 30 minutes, and then subtract this from the total amount of fluids you give later. Um, in our patient, she had a potassium of 5.6. Normally, in these children who are given a bolus, this will come down and it would be sufficient to provide potassium in the bag, and we'll come on to that. The rate is then we'll go into on the next slide. The next stage of management would be insulin, and insulin is often given 1 hour after fluid management. And the reason for that is insulin takes, there's a few factors that need to be addressed. Firstly, insulin needs time to work effectively, and in severe DKA, the poor peripheral perfusion and dehydration reduce insulin delivery to the tissues. So giving IV fluids first improves the circulatory volume, restores renal perfusion, and allows insulin to reach those tissues more effectively and start clearing those ketones more efficiently. Another reason is because it avoids the rapid fluid and osmotic shifts. So immediate insulin causes glucose to drop, water to shift intracellularly as the glucose and ketones are cleared. And if this happens before restoring circulation with fluids, there's a higher risk of cerebral edema, which is a serious complication in children presenting with DKA. The other reason is fluid alone begin to improve hyperglycemia and perfusion. So the IV fluids will dilute the serum glucose, improve renal excretion of glucose and ketones, and begin correcting acidosis before insulin is started. This is a gentler approach and is safer and more physiological. The other reason is because it prevents rapid potassium shifts. And so this is why I was saying that I probably would include potassium in the bag of fluids for our patient, because giving insulin too early can cause potassium to shift into cells before you've assessed and started replacing potassium. Waiting an hour allows for safer electrolyte monitoring and replacement planning, and often the fluids is enough to shift the potassium to a normal range. She'll obviously need close monitoring, and given severe DKA, she'll need a 1-to-1 nursing ratio, which means she will most likely or almost definitely need to go to an HDU or PICU setting. You will therefore need to inform relatively senior members of staff, such as the general pediatric consultant on call, the PICU consultant, or the diabetes consultant on call. So we mentioned earlier that the fluid management. So fluids in DKA is critical and is formulated. So the BSPED have provided a DKA calculator, which simplifies things. But in our scenario, there are a few things to consider. First off, her weight, she was greater than the 99.6th centile. The BSPED recommends a maximum weight of 75 kilos or the 97th centile weight, of weight for age, whichever is lower. So in this case, our child, that would be 15 kilos. The way you would work out her fluids is you would work out her maintenance as the standard way you would. So that's 100 ml per kilo for the first 10 kilos, 50 ml per kilo for the subsequent 10 kilos, and 20 ml per kilo for the remainder of her weight. So for our patient, this would be 1,250 mils over 24 hours. Then you would need to work out her deficit over 48 hours. And this is worked out by her percentage dehydration times 10 times her weight. So in her case, 10 times 10 times 15, which equals 1,500 over 48 hours. So you'd combine the two. You'd combine the two. Um, so 2 times 1,250 plus 1,500, which equals 83.3 mils per hour if you gave the bolus without subtracting it from the total, or 80.2 mils per hour if you subtracted the initial 10 mil per kilo bolus that you gave at the beginning. To give insulin, the first and foremost step would be to stop the pump in this patient, as that is additional insulin, and begin anywhere between 0.05 units per kilo per hour, which is the typical, to 0.7, sorry, that's a typo, 0.0075 units per hour. It is also advisable, as per the BSPED, to continue giving the long-acting Lantus for now, and then essentially because she has a pump, this would be a temporary solution and would be stopped later. The reason I've included this slide is just to highlight that the fluid bolus is an area of controversy and has been debated multiple times. So just to highlight, there is often an overlap between DKA and shock features. Children with DKA often presented dehydrated, tachycardic, and lethargic, which mimic signs of shock, but may not be true hypovolemic shock. Distinguishing dehydration from shock requires a nuanced clinical judgment. So the tachycardia, for example, could be from acidosis, dehydration, or pain. Reduced consciousness could be due to DKA, severity, or cerebral edema. But so this is likely to change, but for now, the current guidance is very clear. It is 10 mils per kilo to all patients over 30 minutes, subtracting from the total, or if in shock, although NICE recommends 20 mils per kilo, it is common practice to provide 10 mils per kilo aliquots of fluid to rehydrate and then perfuse accordingly. If you are requiring more than 40 mils per kilo, and realistically you should be thinking about this after giving the second bolus, you may require inotropic support. So, coming on to the nursing observations, as I said, our patient is very unwell. She's got severe DKA, so she will require quite regular monitoring. So, hourly glucose, ketones, neuroobs, and fluid balance. Now, as a patient with known type 1 diabetes, it's likely she has a continuous glucose monitor, but in episodes of hyperglycemia, it would still be advisable to check via skin prick. She will also need 2 to 4 hourly blood gases and electrolytes, particularly monitoring her acidosis, but also her potassium, and she will need strict input and output. The targets we'd aim for are a ketone fall greater than 0.5 millimoles per liter per hour, a glucose fall of 5 millimole per liter per hour, and the bicarbonate and pH to improve gradually. For any nurses out there, the most useful or the thing I want you to remember that if the blood glucose is less than 14 millimoles per liter, start introducing dextrose, as the patient will be on a fixed insulin regime, which means their blood sugar will consistently fall. Without glucose, there's a risk of hypoglycemia. So, going back to our patient, 6 hours later, biochemically she's improving. Her glucose is 18, her ketones are now 3.2, and her pH is 7.18. But the nurse calls you to tell you that she is behaving agitated. Her mother says this is really unlike her. You assess her, she's alert, she's breathing. Her heart rate is slower at 68, her blood pressure is higher at 118 over 76, and her cat refill is now 2 seconds. Her GCS is 13 over 5. She's more confused and drowsy than she was before, but her pupils are equal and reactive. She's pointing at her head and complaining of pain, and the nurse tells you she has just vomited. Something I didn't mention earlier is that when a child with DK is vomiting, it's always worth considering a nasogastric tube, just because there's always a risk of aspiration pneumonia, which is another potential mortality for these children. But moving on, um, what do you think is happening in our 3-year-old girl? So hopefully you identified that she is exhibiting signs of what could be cerebral edema. This is a serious complication of diabetes and DKA. It is responsible for a high proportion of mortality, though quite uncommon, fortunately. So what would you do? You would need to inform senior staff um, as soon as possible. You would want to give 2.5 mils per kilo, so 50 mils in our case, because she's 20 kilos, of 2.7% hypertonic saline, and restrict the fluids to a half maintenance rate over 72 hours. So I've put the calculation there for you, but that would amount to 46.9 mil per hour. She will likely require intubation by the most senior staff member available and require an urgent CT. With the results, you will discuss this with various people depending on the outcome. So just to talk a little bit more about cerebral edema before we move to our case, we actually don't know what causes cerebral edema, though do know the risk factors. The list is here. The key thing to highlight is that all these risk factors essentially can be broken down to the more severe you are at presentation, the more likely you are to develop DKA. And interestingly, most children with DK typically develop signs of cerebral edema 4 to 12 hours after admission, which has led to the perceived belief that the changes in osmolality between the blood and the brain is responsible for the brain swelling. Um, However, this isn't always the case, and there are cases where cerebral edema has developed prior to fluid administration. And there are some observational studies that suggest that DKA, the acidosis itself, may lead to a subclinical brain injury. In fact, there's been studies that have shown that the more severe the DKA, the more impactful it is on children's cognition, IQ, and memory. There's imaging to suggest that there have been changes in the ventricular size and changes to cerebral perfusion. The more likely thought process is that this is a more complicated um, pathophysiology that is due to a two-hit model that is of vasogenic edema as well as cytotoxic edema from the fluid administration. Um, so uh, We'll move on to the next slide. So going to our patient, her CT head was normal. So she was monitored in HDU. She now looks more alert and she was transferred back to the ward. Her capillary glucose is now 12, her ketones is 5.4, and her potassium is 3.2. So now what would you like to do? So hopefully you identified that her blood sugar is below 14, and so you need to add some dextrose into her fluids, but also identified that her potassium has now fallen to below normal and have given her a potassium correction. So let's see what happens. 90 minutes later, her blood sugar is falling further. It is now 8 millimoles. Her ketones are 4.8, but her potassium is normal at 3.8. What do you do now? Correct. You would escalate her, increase the amount of glucose she's receiving and escalate to 10% dextrose. So 60 minutes later, she is pale. 60 minutes later, she is pale, sweaty, clammy, and her heart rate is 120. Her blood glucose is 3.8 and her ketones are 5. What would you do now? So you would give her a 2 ml per kilo, 10% dextrose bolus. You would stop her insulin and recheck her blood sugar in 15 minutes. If her blood sugar is greater than 4, you would restart the insulin and increase her fluids to 12.5%. This is the maximum amount you can give peripherally, and so you would need to start thinking about a central line for higher glucose administration, or you could discuss with the and diabetes consultant on call who potentially might reduce the insulin. But fortunately, the next morning she's feeling better. Her pH is 7.27, her bicarb's 18, her glucose is 9.2, and her ketones are now 0.6. She's hungry and she wants to eat. What would you recommend? That's right. So you would give some Nova Rapid, stop her infusion, and let her eat. So let's talk a little bit more about the practicalities about that. So when would we start subcutaneous insulin? So the BSPED recommends to start subcutaneous insulin when ketones are less than 1. The long-acting insulin is to be given at the end of day. The way you would switch to subcutaneous is when the child is eating and drinking, you would give the short-acting insulin, keep her on the infusion for at least 30 minutes, and then stop it. For her specifically, she would need her pump re-established, and so once her pump's re-established, we can stop the long and short-acting insulin. A top tip for calculating how much insulin a child needs, especially if they've got a known diagnosis of type 1, is ask them if they have an app on their phone. Most children within this trust will have My Life, where we have preset their carb ratios. So let's talk about insulin a little bit more. So with insulin, do not allow the child to eat carbs if no insulin has been given. You can, however, have fat-rich foods such as cheese as snacks. Ideally, the insulin should be given 15 minutes prior to eating, as that's roughly the onset of the short-acting insulins. So there's two types of insulins that we typically talk about, the long-acting, which have a longer onset of duration and act as our basal insulin, that similar to our pancreas. There are three main types. There is Lantus, which is typically given as a once daily regime in teenagers and has a 24-hour onset. It is otherwise known as insulin glargine. There's Levemir, which is also known as insulin detamir. It's given to children and has a 16 to 24-hour onset, which means that in Kings we often give this as a once daily regime, but there are other trusts which give this as a twice daily regime. And lastly, there is Tresiba, which is often reserved for those patients who are non-compliant and has a even longer onset of action, up greater than 24 hours. The short-acting insulins tend to work within 15 minutes and include NovoRapid and Humulog. If if you were to prescribe insulin for the first time to a new diagnosis of diabetes, the way you would do that is to work out the total daily dose, which would be 0.5 units per kilo per day. And then from that total number, 40% would be the long-acting insulin or the basal insulin. And just to complicate matters, if you were to use Levemir, for example, because it's in two divided doses, you would divide that by two. The rest, so the 60% remaining would be divided by the amount of meals the child has. So if this was a child who had 3 meals, breakfast, lunch, and dinner, you would divide that equally, but you would also need to think about snacks as well. Right. So that concludes this talk. Thank you so much for listening. Just remember that if ever in doubt, you can always discuss all cases with the general pediatric consultant on call, and there is also a on-call diabetes consultant available via switchboard if required. Um, and thank you for listening. I also just want to remark one more thing, and that is with the education. Um, as I said earlier, a lot of these children and parents will be shocked at the initial stages, and also children with DKA often have that cognitive decline. So giving that education takes time, and I wouldn't rush into the conversation of what diabetes is on initial presentation, but maybe throughout the admission. But other than that, again, thank you for listening, and if there's any questions, I'm happy to answer.